My name is Diane Lee. I am with the National Scleroderma Foundation, Texas Bluebonnet chapter, and we're happy to host this presentation today with Dr. Maureen Mayes as our guest speaker. The presentation is going to be on the scleroderma body, head to toe, and inside and out. So really an overview of what scleroderma looks like. And of course, as the National Scleroderma Foundation reminds us, it looks different for everybody. So you'll see some of these that may relate to you and some parts that won't. And if you see some things that don't relate to you, it does not necessarily mean they will happen to you at some point in the future. So just some helpful hints is that all of everybody is muted and the web videos are off for all of the attendees. If you have questions for Dr. Mayes, you should see a control panel pop up on your screen. And there's a line there that says questions. And if you will click on the arrow to the word left of questions, you can type in questions there. And I see somebody has found it already and says, hello from sunny UK. We're glad you're joining us from the United Kingdom. So I'm glad you've found that. So I'm going to introduce a couple people. We have two hosts in addition to me. I am the advisory committee chair for the Texas Bluebonnet chapter and also a support group leader for the Dallas-Fort Worth area. In addition to that, we have Lily Witherspoon. Lily, you can just wave your hand. And she is a Dallas-Fort Worth support group leader. And also Sarita Gibson, a Dallas-Fort Worth support group leader. Lily and Sarita will be watching your questions and we'll be choosing from the list of questions some of the most common questions for Dr. Mayes to answer at the end. So just one or two other things. I want to introduce Dr. Maureen Mayes. I know so many people already know her, but just to give you a little bit of background, Dr. Mayes is founder of the Scleroderma Clinic and Research Program at the McGovern Medical School in Houston. We're so glad she's there. I know many of you have used her and many will. And in addition to that, she broadcasts for us in our education webinars. She's also the author of the Scleroderma book, the very first one about scleroderma, Guide for Patients and Their Families, which is a very comprehensive book. She's published over 250 articles and reviews in medical literature describing her research findings. As we mentioned earlier, she's an active researcher. And her current research is focused on identification of genetic susceptibility factors. And I'm going to let Dr. Mayes talk about that a little bit more as she does her presentation. So, also, I wanted to talk about some of Dr. Mayes' awards. She has received from the National Scleroderma Foundation their Lifetime Achievement Award, and that is reserved for individuals for the National Scleroderma Foundation who have given at least a decade across its entire scope of mission. And also the National Scleroderma Foundation's Messenger of Hope Award. She's on the national board for the Medical and Scientific Advisory Board. She's also on our Texas Medical Advisory Board. So I appreciate that. And this is just a reminder that questions will be available at the end of the presentation. At the end of the presentation, too, we'll show you a little bit more information. But I do want to go ahead and hand this over to Dr. Mayes to get us started on her presentation. So,
well, thank you. And thank you, Diane, for the invitation. And hello to Lily and Sarita. Can you see my screen?
Yes, we can.
Oh, very good. Okay, so this is scleroderma head to toe, inside and out, and it really is an overview from 30,000 feet. But first of all, I just want to explain how doctors diagnose scleroderma. I was on this panel way back in 2013. Actually, I think we started in 2012 to update the criteria. These are really classification criteria. So if you wanted to participate in a clinical trial, and we'll talk a little more about clinical trials in a few minutes, this is how we say, yes, you have scleroderma, you meet the criteria. I have several patients, many patients actually, currently and in the past many years, who I know have scleroderma, but they don't quite meet the diagnostic criteria. And this is based on actually a scoring system. So if you have skin thickening of the fingers, so involving the fingers at least, and extending over the back of the hands, then that's considered very typical and diagnostic for scleroderma. And that gives you a point score of 9. Now, if you only have skin thickening of the fingers, or if you just have puffy fingers, then that you get either 2 or 4 points. If you have ulcers at the tip of the fingers or these tender pitting scars, it's not quite deep enough to be considered an ulcer, but it's still there at the tip of the finger. That gives you a couple of points. If you have these telangiectasias, and I've got a photo later on, we'll take a look at these, that gives you a couple of points. And then abnormal nail fold capillaries, another couple of points. And if you have internal organ involvement, that's typical for scleroderma, either scar tissue in the lungs, which we call interstitial lung disease, or high blood pressure in the blood vessels to the lungs. It's called pulmonary hypertension. Then again, a few points. And Raynaud's phenomenon, which actually should be put probably at the top of this list, because almost everybody with scleroderma, 95%, but not absolutely everybody, by far the majority of people will have Raynaud's phenomenon, and that gives you a few points. And then in addition to all of these clinical findings, there are laboratory tests that will say, oh yes, this puts you in the general category of scleroderma. And if you have these typical laboratory tests plus the clinical findings, then we say, oh yeah, you have scleroderma, I'm sure about the diagnosis. And at the bottom, you can see, so you have to get a score of 9 to be called definite scleroderma. And then sort of 7 and 8 is considered probable scleroderma, and less than that is probably not scleroderma, but it's one of those gray zones. And in rheumatology and in general medical practice, I think we live in the gray zone. So let's talk about skin involvement. There's something called a skin thickness score, also known as a modified Rodnan skin score. Dr. Rodnan was one of the early pioneers in clinical scleroderma, and he established this skin counting score, and he has been absolutely influential in establishing scleroderma as an entity that we can study and that we can treat. Now, the skin thickness score varies from 0, which is normal, to 51, which is as bad as it can get, and it's over 17 body areas. So let me give you an example of a patient I saw a couple of months ago with early diffuse scleroderma. So here's his skin score. So it's right and left. Fingers, and 1 is mild, a score of 1. A score of 2 is moderate. A score of 3 is severe. So fingers were severe, back of the hand severe, forearms severe, upper arms mild. And this is sort of typical that the fingers are much more affected than other areas closer to the center of the body. His face was involved too, chest very involved, abdomen moderately, and then thighs, legs, and feet. So actually, it's just arithmetic. Once you've established this score, then you add it all up and you end up with a total score. So what do we call limited? What do we call diffuse disease? I think these are terms that many patients have heard. There's also a term of CREST, but we'll get to that in a couple of minutes. But if you have limited skin involvement, and this just talks about skin, it doesn't reflect internal organ disease, but limited is skin thickness that's confined to areas that are below the elbows or below the knees. So hands, forearms, face, lower legs. Feet and lower legs. The face can be involved in either limited or diffuse. And then diffuse skin involvement is the hands plus more central areas of the body, the above the elbows or knees, so involving the upper arms, chest, abdomen, thighs. So it doesn't consider, as I mentioned, internal organ involvement. So you can have limited skin involvement plus GI involvement. You can have limited skin plus lung involvement, or diffuse skin and GI or lung involvement. So really, limited versus diffuse is based solely on the degree of skin involvement or the pattern of skin involvement. And I tend to do skin scores pretty much on everybody, every visit. So skin scores don't include some things. For example, there's some things that affect the skin, but not skin thickness. It doesn't include Raynaud's phenomenon. Finger ulcers, calcium deposits, telangiectasias, which are a particular form of red spots that we see. Not all red spots on the body are telangiectasias. Pigment changes. Many people will have either increased or areas of spotty decrease in pigment, and the skin isn't thick, but the pigment change is there. So just because your skin is darker or lighter than usual doesn't mean that the skin is thick in that area and it's not counted as affected in the skin score. And then there's the snail fold capillaries. I've got a couple of photos of those because this is something I do in the clinic on a regular basis as well. But the skin scores are usually only done at scleroderma centers. It's something that it's somewhat difficult to do. It took me a while to get really good at it, to be able to distinguish mild, moderate, and severe skin thickening. We now have training sessions for people who want to participate, for physicians who want to participate in clinical treatment trials, because that's based very much on the degree and extent of skin involvement. Oh, and hair loss. That's some people with scleroderma are very affected by hair loss, but it's not considered part of the skin scoring system. So this is something that I'm sure most people in the audience who are patients are very familiar with. This is a photo that was sent to me by one of my patients many years ago, because it's dated 2009. And you can see that she's doing it with one hand. She's taking the photo with one hand, and her keyboard is in the background. But this shows two phases of Raynaud's: the phase of pallor when it loses color, and the phase of blue-purple discoloration known as cyanosis. This is a little atypical in terms of Raynaud's phenomenon, because frequently many fingers will turn white at the same time or all be blue at the same time and have this either tingling, burning sensation or be totally numb. And not all people with Raynaud's have scleroderma. Most, as I mentioned, 95% of scleroderma patients will have Raynaud's, but the opposite isn't true. As a matter of fact, there's a condition, primary Raynaud's symptom or disease, that's common in the general population. It's been estimated that 5 to 10% of adult US women and 1 to 5% of men will have problems with Raynaud's. Many people in this category don't consider it a disease. They consider themselves to be cold sensitive. They don't get ulcers. Nothing else happens. The rest of them is fairly normal or regular. And it's primary Raynaud's. And this is purely a spasm of the blood vessels. And once the cold challenge is gone, the blood vessels return to their normal caliber. And that's different for secondary Raynaud's. Primary Raynaud's doesn't ulcerate. And if you do blood tests like the ANA, the screening test for lupus, scleroderma, and some of our other autoimmune connective tissue diseases, the ANA will be negative. But one thing, the caveat is that there is a false positive ANA in about 5% of the general population. So as you can imagine, it can be very difficult for a physician to decide if somebody has primary Raynaud's, because if their ANA is positive, then that raises the question that maybe they've got secondary Raynaud's and that something else is going on either currently or will develop in the future. But if you follow a patient, if I follow a patient for 5 years, well, say I see a patient in the clinic on one day and they say that they have been referred to me by their primary care physician or by their rheumatologist because they have this condition, Raynaud's, and because their ANA is positive, and that this has been going on for 2 or 3 years already. Well, I don't have to follow that patient for very long because if in 5 years after the onset of the first Raynaud's attack, if 5 years go by and nothing else happens, the fingers aren't puffy, they don't have skin thickening, they don't have puffy fingers, then I can say, you're fine, I don't need to see you again. It's been 5 years, nothing's happened, and it is very unlikely that you're going to develop anything else. That's sort of nice when I get to tell a patient goodbye because they're too good. And also, Raynaud should be on both sides. It frequently will start off on one hand and commonly the dominant hand, but within a few episodes, a few weeks, at least a couple of months, it will involve also the other side. If it remains on one side, then we worry about a blood vessel problem in the blood flow in the arteries to the hand on that side. It can be narrowed, and that's why they're getting this exaggerated response to cold. So secondary Raynaud's phenomenon, of course, scleroderma, we all know that. And I'm really talking about systemic scleroderma, systemic sclerosis. That's abbreviated as SSC. I'm not talking about localized. I'm not talking about morphia, which is a skin involvement. I'm talking about SSC. Now, you can also have Raynaud's in a condition called mixed connective tissue disease. This is an overlap, a little lupus, a little scleroderma, a little myositis, and the Raynaud's, classical Raynaud's can occur in that condition as well. And then there's some miscellaneous conditions, something called cryoglobulinemia, and frequently doctors will test for cryoglobulins in the blood if somebody presents with Raynaud's and nothing else. And there's this repetitive vibratory trauma that actually I have never seen in 30, 35 years of being interested in scleroderma and Raynaud's. And this happens if people have a significant ongoing chronic exposure to something like jackhammers, because that constant trauma, sort of a micro trauma, can damage the blood vessels to the fingers. And then vascular narrowing if it's only on one-sided. And one thing about that, being able to treat that vascular narrowing, is sometimes the interventional cardiologist can thread a very fine catheter through that blood vessel and dilate it. But that's usually, not always, but usually not possible in people with scleroderma, Raynaud's, both sides. So before I go into internal organ involvement, remember, not everybody gets everything. Every patient is different, as Diane mentioned. So what are the telangiectasias, also known as red spots? This is a patient of mine with a lot of telangiectasias, typically on the palms. They can also be on the face, on the arms, on the upper part of the body. They are almost never on the legs for reasons that I don't understand, and I don't think anybody understands. One of the characteristics of this is that if you press on it for half a second, it sort of goes away, but as soon as you release the pressure, it comes back again. So there are fixed red spots that don't qualify as telangiectasias, and they're also common as people get older. So what about the calcinosis? And this is part of a condition with scleroderma called CREST. I don't like that designation because it it tells you that people have some features, but it doesn't distinguish between limited and diffuse disease. So I don't find it particularly helpful. But this is also a patient of mine. I don't have the date on the photo, taken a few years ago. And this is calcium deposits that occur on his thumb. Now, you would think that perhaps a hand surgeon could go in and just remove those little calcium deposits, because once they erupt through to the skin like this, they can be very painful. Well, here's the problem with a surgical approach to removal of calcinosis. And here is his x-ray, and you can see the thumb here and the calcium deposits, although when you look at it visually, it looks like it's a couple or maybe three little discrete areas. Actually, there's a whole collection of calcium in under the skin. And if you were to try to remove this, you would end up removing much of the tissue of the entire pad of the thumb, which is not a good idea. So what about nail fold capillaries? I have a little handheld capillary scope that will dilate the, or will magnify the image for a fold. So this is what you would expect in normal nail fold capillaries. At the top of the photo, you can see the fingernail, and then right underneath the nail, the clear space, that's the cuticle. And then you can see the little blood vessels that are, for nail folds, pretty evenly spaced. And although there's a little bit of variation in their diameter, it really isn't that much. And this is considered normal. So I'm about to show you what is not normal. And this is the same, this isn't the same person, but this is the same kind of view, a little more magnified. And at the top, you can just barely see the fingernail. That looks very pale here. And then under the nail itself, there is thickened cuticle. And then below the cuticle, there are these big dilated loops of capillaries, and they are separated by areas where there are no capillaries. And this is considered really abnormal and is typical in scleroderma, but sometimes in a condition called dermatomyositis. But this is something we're looking for, and if you'll remember one of the first slides when I was talking about the criteria, if you have abnormal capillaries, it gives you a couple of points or 3 points in terms of saying, oh yes, this is likely scleroderma. So that's sort of a quick run through the external features of scleroderma that can be seen easily on physical exam. But let's talk about how scleroderma affects the interior organs. And again, remember, not everybody gets everything. So one of the most common things that we see in scleroderma is esophageal motility problems, GI problems. It occurs to some extent in the large majority of scleroderma patients. Again, not everybody, but about 85%. And the symptoms are heartburn and reflux. But if there are non-patients out there listening to this, you can think, oh my God, I've got heartburn. I eat spicy food, or I eat something and then lay down, and you get the reflux and it burns because it's stomach acid in it. Yeah, reflux, heartburn, esophageal dysmotility is not part of the criteria because it happens so commonly in the general population. But scleroderma-related heartburn, scleroderma-related reflux is something that is more severe, more frequent, and more common. So it certainly is something that we need to identify and treat. And treatment is with medications and also with what we call lifestyle changes. So the medications, there are proton pump inhibitors, omeprazole, esomeprazole, lansoprazole, pansoprazole, that are approved and very, very helpful in scleroderma related and in other related forms of reflux and heartburn. There's also something called a class of drugs called H2 blockers. These are cimetidine, famotidine, which is Pepcid over the counter, and they're a little helpful, but not as good as the proton pump inhibitors. Then there are other medications, sucralfate that can coat the stomach, and Gaviscon, some other things, Tums, of course, which helps in the short term, but half an hour later, the heartburn reflux symptoms can come back. So what do I mean by lifestyle changes? Well, avoid eating late at night, within 2 or 3 hours of going to bed. Elevate the head of the bed, and usually pillows are not good enough because you turn on your side and you fall off the pillows. So elevating the head on blocks can be very helpful so that the entire bed is at a slant. But unless you have one of these separate beds, your bed partner or sleep partner may not enjoy having the head of the bed elevated. And then, of course, avoiding trigger foods. And this is different for everyone. Some people say that acid foods like citrus juices and citrus fruits are not good. Other people say, oh, I can eat those, but I can't eat any tomato sauce. So it varies from one person to the next. So in addition to affecting the esophagus, scleroderma can also affect the stomach and the lower part of the bowel. If it affects the stomach, it decreases the ability of the stomach to get rid of food or to pass food along, and there can be delayed gastric emptying. This isn't specific for scleroderma. Some people with diabetes will have delayed gastric emptying, and some people just have a slow gut and don't have anything else. Then after gastroparesis, there's diarrhea or alternating diarrhea and constipation, which is typical for irritable bowel disease, but not in the same way that it affects scleroderma. Treatment, well, it varies widely, depends on individual circumstance. So, frequently it's treated with just to alleviate symptoms. If there is something called bacterial overgrowth, then antibiotics can be helpful. So it really varies from patient to patient. So going on to something else, the lung. Scleroderma can affect the lung in a couple of different ways. And what does it mean to have scleroderma affect the lungs? Well, there is this scar tissue, collagen, which is the same kind of scar tissue that accumulates in the skin, that can accumulate in the lungs as well. Not with everyone, but in a certain proportion of patients. And it starts in the bottom of the lungs and then may stay in the bottom of the lungs forever, or it can progress and include the mid part of the lungs. So here is a chest x-ray that shows pretty advanced scleroderma. If you look at the top of the lungs, you see it's mostly dark if you look at it above the clavicles. And this is the way lungs should look, because lungs are a little bit of connective tissue and a lot of air spaces, air sacs. But as you go down closer to the base of the lungs, above the diaphragms, you see that the photo becomes more and more opaque, more and more white. And that white is scar tissue, collagen accumulation that is blocking out the small air sacs. And if you do a CAT scan, and this is done with the patient lying on the back, as you can see, and the big white blob in the middle is the heart. The couple of holes in the at the sort of bottom of the heart shadow Those are the breathing tubes, the bronchial tubes. So they're filled with air and they look dark on an X-ray. But then as you go out to the sides, you see all this white stuff. That's the collagen. You see a few holes. Those are cysts. And there are some areas that look very dark. The very dark places are normal. Again, air shows up as dark or black on an X-ray. So this is someone with fairly significant interstitial fibrosis, which is the scarring of the lungs that occurs in scleroderma. Well, how do we diagnose it and how do we treat it? Well, first of all, you have to determine if it's present. You may not have symptoms in the beginning, and the symptoms are usually shortness of breath with activity. But there's a lot of reasons people get short of breath. It can be that you're out of shape. It can be that you smoked in the past and you have COPD. It can be that you have asthma. But the symptoms of shortness of breath, especially in very early interstitial lung disease and scleroderma, may not have any symptoms at all. And how do you look for it as a physician? Well, we screen by pulmonary function tests or PFTs. If they're abnormal, then we need to do a CAT scan because a chest X-ray simply is not sensitive enough to pick up early ILD. And if ILD is present, oh, one thing I should mention before we leave the idea of pulmonary function tests is that normal is determined by 80 to 120% of predicted. So there's such a wide variation in normal. And the percent predicted values are based on lots of people of the same gender, height, and weight. So, of course, if you're a very tall person, then you would expect that your lung function ought to be greater than, so if you're 6 feet tall, your pulmonary function tests are going to be much greater than somebody who is 5 feet tall. That's the normal variation from person to person. But if you have somewhat abnormal pulmonary function tests and you have a CAT scan that suggests that there is more connective tissue or scar tissue at the base of the lungs, and there's concern for the development of interstitial lung disease, so it's there, well, is it getting worse or is it mild and stable? I tend to do annual pulmonary function tests. I don't like to do annual CAT scans, but do annual pulmonary function tests to see if it's changing. If somebody has newly diagnosed, a new onset of what looks like interstitial lung disease in association with their scleroderma, then I may want to do pulmonary function tests in 3 months and certainly in 6 months rather than waiting for an entire year to go by. Scleroderma ILD tends to be fairly slow in progression, so we do have time before considering treatment to determine if it's getting better, getting worse, or really staying the same. Well, what are the treatment options? Let me tell you that 20 years ago, that was pretty much zero, and things have changed for the better. A few things, I guess, in the last 20 years has changed for the better. But anyway, we now have in the US approved, FDA approved, and absolutely demonstrated effective treatment for scleroderma lung disease. And these include mycophenolates, a medicine called nintedanib, the trade name, brand name is Ofev, another one, pirfenidone, brand name Espree, tocilizumab, cyclophosphamide, which is old and toxic in many ways. And then there are others, several in clinical trials. So I think that the approach to treatment, particularly in scleroderma ILD, is very promising. We now, if we can't cure it, at least we can treat it. And if we can't eliminate the progression, we can slow down the progression of disease. That's still not true for everyone, but we have far more treatment options in our armamentarium than we have in the past. So one thing I wanted to mention, because it's important, but it is uncommon. It only affects somewhere between 5 and 10% of scleroderma patients. But when it happens, it's one of the few things that happen in scleroderma that will happen quickly and can damage organs. And that's scleroderma renal crisis. So what is it? It's the sudden onset within days to a few weeks of extremely high blood pressure with worsening kidney function. So people can go from absolutely normal blood pressures, 100 over 60, even lowish kind of blood pressures, to pressures of 200 over 100 in a matter of a couple of weeks. That's very unusual. That's not part of the normal increase in blood pressure as the day wears on. For most people, blood pressure is lowest in the morning when you first get up. And then as the day goes on, you become more active, maybe more stressed, and the blood pressure will go up a little. And then next morning, it goes back down to the usual, whatever is usual for you. That's not the case here. So who is at risk? Well, this is also called hypertensive emergency, malignant phase hypertension, and it existed before it exists in the absence of scleroderma, but it's the risk is increased in scleroderma. And usually it occurs within the first 5 years. So it's not something that will, if you have stable scleroderma, 10 you are not at risk 10 years later or 15 years later. It's treatable with medication. There's a class of blood pressure medications called ACE inhibitors that are effective. And of course, like almost everything in medicine, it's best if identified early and treated aggressively. It can lead to renal failure. And if that occurs, it's one of the few conditions in medicine where renal failure that requires dialysis can be reversed. But again, you have to get really good control of that blood pressure. And in early diffuse disease, I ask people to take their blood pressure on a regular basis, 2 or 3 times a week, keep a diary, and call me if it goes over certain parameters. And that's different for each person depending on what their normal resting blood pressure is. And one thing, we should try to avoid prednisone at doses greater than 10 milligrams a day, because that's associated with an increased risk of renal crisis. But sometimes, because of other symptoms and other involvement, organ involvement in scleroderma, we are stuck with giving prednisone at doses that we would prefer not to, but the clinical situation requires it. Oh, I'm going to talk just a little bit about pulmonary arterial hypertension, which is the other cause of shortness of breath in scleroderma. And unlike the renal crisis or risk for renal crisis, this tends to be a later complication. So people can have limited disease, stable disease, little Raynauds, some reflux, everything looks pretty good. And 10, 15 years later, they can develop shortness of breath with clear lungs on exam, pulmonary function tests that show normal flows, which is the forced vital capacity, normal volumes, normal total lung capacity, but this diffusing capacity, this DLCO, is low. And so you have somebody who comes, as a physician, who comes into the office and says, my breathing is just not as good as it was 6 months ago. That one of my patients said, when he was still working, when I go out with my friends in the middle of the day for lunch, they're all walking and they think it's a normal pace, and I'm short of breath. I can't keep up with them. And this wasn't the case a year ago. And I listened to their lungs, and their lungs sound fine. And if you do an in-office pulmonary function test, which is just sort of the asthma test, looking for the forced vital capacity, that can be quite normal. But to do the full pulmonary function test, the DLCO is low and out of proportion to the rest of the lung function. CAT scan will be normal because it's not in the lungs. So you can get a screening echo, and I like to do echocardiograms annually or every couple of years on patients looking for this, screening for this. But the echo can indicate maybe it's there, but it takes a right heart cath to actually measure the pressures and say, oh yeah, this is pulmonary arterial hypertension. Now, most people are familiar with the left heart cath that says whether or not you have coronary artery disease, whether or not you're at risk to have a heart attack, and you can have bypass surgery or stent placement to sort of fix the atherosclerosis, the coronary artery disease. But this isn't on the left side of the heart. This is on the right side. This is the part that goes from the right side of the heart to the lungs, and pressures will be high there. And the good news, if you were to develop this, is that we now have at least 6 approved treatments, and treatments are coming out all the time for pulmonary hypertension. So I think, again, if you had your choice, you wouldn't want to have this, but at least if it's caught, if it's identified, caught early and treated, things will be good. Well, what about other symptoms? And I know we've talked about skin, a little bit about ulcers, and GI and lung involvement, but what about everything else that people complain to me about? Well, muscles, joints, and fatigue. Each person is different, so approaches to therapy have to be tailored to each individual patient. Again, try to avoid steroids like prednisone at doses of greater than 10 milligrams a day. If steroids are needed, we try to limit the duration to as short as time as possible, and sometimes that's not always possible. And then fatigue. Oh, I think most doctors find that this is, and patients, of course, that this is a very frustrating symptom to try to deal with. I think it's the most difficult symptom to treat. We tell people, well, make sure you get plenty of rest, but frequently the fatigue associated with autoimmune disease is not related to the amount of sleep or the quality of sleep that you get, but that's something that can be addressed and try to be optimized. And then regular exercise, even walking, whatever you can do on a regular basis will increase your mood and improve your sleep. And that's about all I'm going to say about fatigue. But let's talk about clinical trials, which, of course, determine future therapies. And how is it determined that a medication works or that it does not work? Well, this is what we look for in our clinical treatment trials. It has to be randomized. So people don't choose to be on the supposed active medication or the placebo. It is determined usually now by a computer according to chance. Should be double blind so that the patient is not aware of what they're on. The doctor is not aware of what they're on. So if they develop something that could be a side effect, we always record it in our clinical trial reports, but not knowing whether the patient is on the new medication or the placebo keeps bias from coming in, because people can get headaches to anything. They can get worse, they can get a skin rash because of other things that are going on, not necessarily because of the medication. And it's controlled, either placebo controlled, and now most of the time in our clinical trials, people stay on their same medications. It's called standard of care. So if they're on myclophenolate, they stay on myclophenolate, and we add the study medication or placebo to whatever background therapy they have. And it's usually tried in what we call a homogeneous patient population. So we look at everybody with early diffuse disease, or everybody with lung involvement or everyone with a certain type of GI involvement. And then we're trying to make the comparison related only to the new medication, not related to background therapy or related to the fact that we're trying to compare somebody with 10 years of scleroderma versus somebody who is with new onset scleroderma within the last few months. And you have to have a clearly defined outcome. Is this going to be a trial for skin involvement so that we're looking for a decline in skin thickness score? Or is this a lung involvement? So we're looking for changes in their pulmonary function test or their CAT scan, et cetera, et cetera. And you have to know this ahead of time, set it up ahead of time. And then if sponsored by a pharmaceutical company, what they're looking for is an application for FDA approval. And these days, actually, there is a great deal of interest in and enthusiasm for taking medications that are already on the market, but for something else, and applying them to scleroderma. This is one of the ways that tocilizumab, which was approved for a fairly long period of time for rheumatoid arthritis, and then people said, well, if it works for RA, does it also work in scleroderma? There is a scientific rationale that it would be helpful, and in fact, it was helpful and did get FDA approval. So that's another way to look at, not necessarily a totally new drug that hasn't been used in people before, but it can be an older drug that is now being used for a new indication. And there's a difference between standard of care and the FDA-approved indication. For example, mycophenolate in scleroderma skin and lung disease is not FDA approved to be used in scleroderma, but it has been demonstrated to be effective and is considered standard of care and is covered by most insurers. A little bit of a difference, but anyway, I just thought I'd throw that in. And finally, here is the UT Scleroderma team. There are a lot of us. I think you might recognize some people. There is Pat, who is in the second row, the second from left. She's my clinical research nurse. There are other coordinators, lab people, dermatologists, of course, rheumatologists, there's a cardiologist, and pulmonologists, all of whom are interested in various aspects of scleroderma. These are great people. I am so fortunate to be able to work with them. And we have a multidisciplinary conference once a month where we go over cases and discuss them, how I would treat this from a rheumatology point of view, or Dr. Asasi, who is there, and then how a pulmonologist would approach treatment, or a cardiologist. So it's really helpful to have a team. Okay, with that, I think I will sign off. And if Lily and Sarita can suggest some questions from the chat box.
Okay, I think we're ready to ask you some questions. Lily, do you want to start the first one?
I sure will. Okay. If surgery is not a viable option for calcinosis, what would you recommend for pain and discomfort? The areas that are most painful, the calcium deposits, are underneath the skin and never come to the surface. And that's from Desiree James.
Okay. Let's go to the next question. The reason I say that is there are multiple reports in the literature about things that can be helpful in calcinosis related to scleroderma. I have never found them helpful. There are no controlled clinical trials. There are only a few case series. I've tried lots of things. So bottom line, Usually surgery is not recommended. It depends on where the calcium deposit is and how extensive it is. The x-ray I showed, with the very extensive involvement of the entire tip of the thumb, that's not amenable to surgery. If there are calcium deposits elsewhere that are more defined, they might be able to be scooped out. You have to make sure that you've got an x-ray, you know exactly where all the calcium deposits are. But in terms of medication, there's very little. Sometimes these can get inflamed. So red, swollen, more painful than usual, which would be an indication that there's a secondary infection, so that an antibiotic. Mycophenolate, does that help? Helps with the skin. I've never seen it help with calcinosis. There's an antibiotic, minocycline, that has been used and might be helpful, but I'm somewhat skeptical.
How often should an interstitial lung disease patient get a CT scan of the lungs, supine and prone, inspiratory and expiratory, and how concerned should we be about radiation exposure? I know that's a very specific question.
Yeah, to have this supine and prone position, so that's you're lying on your back, which is kind of typical for a CAT scan, but then they have people turn over and they have one lying on the stomach. You're right. The reason that I don't do frequent CAT scans is because of the radiation. So the pulmonologists are a little less concerned, and they'll do CAT scans perhaps twice a year. I would prefer to limit them to annually. Depends if the pulmonary function tests are stable. The advantage of the pulmonary function tests, they are somewhat quantitative, and of course, it does not require any radiation. The way they do the high resolution CAT scans with both prone and supine positions these days requires much less radiation than even 5 years ago, because they can do some sort of computer enhancement and see more than they were able to with less radiation. So I'd limit it if possible to no more frequent than every 6 months, especially if there's no concern there's something else going on.
Okay, thank you very much. Lily, do you have another question?
I do. Is mycophenolate used for ILD short-term or long-term? And that comes from Janelyn Patterson.
Yeah. Now it's considered long-term, and long-term being 5 years or more. There is some interest, but study has not been done yet. But there is interest in doing what we call a withdrawal study after people have been on the medication for an extended period of time, say 5 years. Their pulmonary function tests are stable, the CAT scan looks stable. Is it safe in those patients to stop the mycophenolate? That's a question we don't know. All of the studies that have indicated it's effective have been short-term studies, and by that I mean 2 years. 2 years show that it improves or it stabilizes patients, and they tend to either continue to be stable or to have very, very slight decline over time. And I should say that everybody's lung function declines over time. Old lungs are not as good as young lungs, so you have to take that into consideration. Is the degree of decline more than you'd expect in somebody who goes from age 45 to 46 or 45 to 50? And if it's within the general parameters of age loss, then that would still be considered stable lung function. So what I do, and I think everybody's a little different, I try to lower the mycophenolate dose to a minimum amount and then keep that and not totally stop it. One thing I should say about mycophenolate is that it should not, must not, cannot be used in pregnancy. And if somebody is planning on becoming pregnant, stop the medication and hold off for at least 3 months before trying to get pregnant because it can affect the baby.
Diana Scooby asks, can digestive issues like gas and hernia cause PFT to be low?
Yeah, this is a concern about reflux that, especially if people are not really elevating the head of the bed at night, so they can have uh, aspiration of stomach acid or stomach contents into the lungs at night. Now, sometimes people know this because they will wake up sputtering, coughing, short of breath. But sometimes, even, especially if they're on one of the proton pump inhibitors that decreases acid, so that what is coming up in the middle of the chest is not acidic, it's neutral, so it's not as irritating. But still, if you breathe any of that into the lungs, that can irritate the lungs and can cause inflammation that leads to interstitial fibrosis. So, yeah, there is a connection between reflux and ILD, but that's not the whole story. Many patients who either don't have reflux or who elevate the head of their bed, do all the usual anti-reflux precautions, they still have interstitial lung disease, and it's just on the basis of their scleroderma. But that's one of the reasons that people with reflux should really do all of the lifestyle changes as much as you can. The other thing, if you are overweight, especially if it is particularly in the central part of the body, as tends to happen as people get older, that will, if you're lying on your back or even on your side, it pushes against the abdomen. That tends to worsen reflux, especially if the valve at the bottom of the esophagus into the stomach is weakened, as it frequently is in scleroderma. So you put a little bit of pressure on it, and it makes reflux worse.
Thank you. Lily, are you ready for the next question?
I am. What about weight loss? My daughter has been recently diagnosed, has lost at least 80 pounds.
Yeah, there's several reasons for weight loss. One of them is diarrhea, so that no matter how much you eat, you're losing those calories in the stool because of the diarrhea. And that's usually due to this condition called bacterial overgrowth. That can be helped with an antibiotic. Now, the other reason for, well, there are several other reasons for weight loss. One of them is if there is dysmotility in the esophagus, people have trouble swallowing. So they eat more slowly, cut their food into tiny bits, avoid certain foods like meats, breads, which can have a lot of calories. So even though they think they're eating the same amount, actually they've decreased the total calories. And the other cause is that there can be inflammation in the body. And once there's inflammation, that uses up calories. So people again think, well, I'm eating the same amount, but their body is using more of the calories, and that results in net weight loss. So I think people have to be very careful to look at all of those reasons. And If you're overweight, of course, it's good to lose weight, but if you are fairly normal weight, or if you are losing weight quickly and there's no unintentionally, it can be frightening and it needs to be identified as the basic cause and then treated with that. One thing about trouble swallowing, there can be stricture or narrowing of the esophagus that causes the trouble swallowing. And the gastroenterologist in an upper endoscopy procedure where they pass the tube into your throat and into your stomach, they can see that there's a stricture and they can dilate it with the endoscope. And that can be very helpful for swallowing. But in the absence of an actual stricture, then it probably is just slow moving esophagus, requiring people to eat more slowly.
Liz Price, she asked, she said recently she had a PFT that showed increased residual volume. And she asked, could this be related to the start of pulmonary problems if I have limited scleroderma?
Increased residual volume usually means that you're not breathing out as much air as you should. So you've got some air trapping in the lungs, and that's more of an asthma or bronchospasm kind of picture than an interstitial lung disease kind of picture. So just if the forced vital capacity is normal and the diffusing capacity is normal, the increased residual volume is probably not caused by scleroderma-related problems.
Thank you, Dr. Mayes. We have about 50 questions, so we may talk about bringing you back at another time. Seems there are a lot of questions that people have about different aspects of the disease. So we so very much appreciate your presentation today, giving us a good overview of scleroderma and what it looks like. We also had some questions about morphia. We will continue this series on the scleroderma body with a presentation every other month. We will miss the month of July because the National Scleroderma Foundation will have its national conference. So please sign up for that. There'll be great speakers there. And then we'll start again in September. So watch for the Texas Bluebonnet Chapter Facebook page for more information. It'll be the third Saturday of September at 11 o'clock again. And we will go through a whole series of speakers from our Texas Medical Advisory Board on different aspects of the scleroderma body. But we wanted Dr. Mayes to get us started off today with an overview, having written the book on scleroderma. So we thank you for joining us, and we will send out a survey later this week and ask you to respond to the survey. So we will try to figure out a way to just do a whole question and answer session. Maybe we'll do that during one of our sessions, but we know there were a lot of great questions. I'm sorry we didn't have time to answer all of them, but Dr. Mayes, we really appreciate you just being willing to do the impromptu questions on a very wide variety of disease aspects. So thank you all for attending today. We appreciate your attention and do hope you will stay connected with the Texas Bluebonnet chapter through any one of our social media channels. So thank you very much, everybody, for your time today. We certainly appreciate it. And Dr. Mayes, thank you so much for being our guest today and for sharing your wealth of knowledge and many, many years of experience with us.
Okay, well, thank you. Have a good day.
Thank you, Dr. Mayes. You do the same. Thank you.